Buddy, it's time for our weekly health talks with Dr. Trinh. The one show, the only show that shows you the path to a healthier life. One conversation at a time. And today, well, we got a mouthful. Long titles, complicated ideas. We're going to try and make it simple for you, right, Dr. Trinh?
We're going to try.
We're going to try. Introduce your guest, because I could never even say her title. I couldn't even get the title out, much less understand what she's talking about here.
Oh, this is my friend, Christine King, assistant professor at the University of California, Irvine, professor of teaching and in the biomedical engineering department. And she just came back from Vietnam with our tongue out team, and we had a great experience there.
So welcome, Christine. And then the first task you have this morning for our average, our regular old Joe listeners like me is, what the heck is bioengineering in medicine? I sort of get it, but I don't want to guess. Explain that field that you teach in here at UCI.
Sure. It's the development of medical devices. So every physician has to use a lot of devices and a lot of different technologies within their own procedures and daily lives. We build them.
Wow. That was so much easier than I thought it was going to be. All these little devices that make, is it just the stuff that the doctors use, or is it the stuff they stick in my body to make the fake joint and the heart pump and the things that are all going to turn me into the bionic man, if you remember that series from the 60s here?
Yeah.
I think that's where we're headed, aren't we? And UCI has been a leader in this. I'm here at the UCI's Beal Applied Innovation Center, another fancy title for where they're trying to take that technology you guys are developing and turn it into something, either license it or turn it into something.
That's great.
Led by the university's chief, what does he call himself? Chief innovation officer. So
I work with the innovation officers to help develop startup companies with our students. So I specialize in women's healthcare, where we're building medical devices for women to eventually become startups and to be licensed out to larger companies.
Like what? Well, give me some stuff on the horizon. You don't have to give any secret stuff away, but give me some ideas.
Speculum. So anytime any of your female friends, colleagues, wives, whatever, has to go to a OBGYN, it's right. The very painful thing that makes an annoying clicking sound when they have to get tested for cervical cancer.
Wow. Okay.
Ooh.
All right. Anything else cutting? Give us a hint of something that's futuristic. It's not there yet, but you see it on the horizon.
We're doing a lot of research right now to help treat postpartum hemorrhage. So this is to keep women from bleeding out and dying after they give birth or have a C-section.
And is that still common today? You somehow think we figured all this stuff out. Women get C-sections all the time. I don't think they're worried about bleeding out and dying here.
Well, they shouldn't be. So with our novel technologies, we want to make that number go to 0.
Wow. Okay. And where is it at roughly?
It's not too common. It's pretty rare, but the number of C-sections, we actually have the highest number of C-sections in the world. Wow. Okay. And that's not a good thing. A lot of women don't want C-sections, or at least want to make their choice of how they give birth.
And last question, then we'll get down to the real topic here, because you opened a door here. Why are we the highest number of C-sections? And I'm going to talk, this is going to horrible, women are going to scream at me, but it seems like it's almost a convenience thing. They're scheduling when to have their baby. And so I can't predict when the baby's going to come, so we'll just set it for next Tuesday at 2:00.
So just like me being anti the Roe v. Wade decision, women should have a choice. Right. So you should have a choice on whether or not you want a C-section. And so there are times when we have to have an emergency C-section.
Clearly, yeah.
And these happen more often than not because of the way we are monitoring the fetus and detecting what we call fetal distress, whether or not the fetus is in distress, and therefore we have to do a C-section. So it's another technology that we're working on to see if we can better detect fetal distress more accurately so that we can make a better decision on whether or not a C-section should happen.
So am I? You carefully skirted my question, and I'm not trying to pin you on something, but it seems like it is we're in a busy society. Everybody works. I think when my daughter had her second child, I think they were talking about having a C-section because they predict kind of when the baby's going to come and it's not coming, and then the doctor says, well, why don't we just set up a C-section here, and we'll Mike's schedule, your schedule, we'll just do it next Tuesday here. And everybody's sort of amazed, but am I overstating that? Is that
Yeah. So oftentimes we want to have a medical reason to put you under the knife.
I would think so. Right.
But there are people who, if it's a personal decision, they can have that. There are also women out there who personally want to have a vaginal birth or a natural childbirth.
Yeah, clearly. My daughter did.
So you want to make sure they have those options still.
Okay. All right. Dr. Trinh, what do you think here? Is this UCI cutting edge stuff here? No pun intended. I didn't mean to say the cutting edge.
Absolutely. And this C-section device isn't just for the U.S. I see just potential use around the world because bleeding post-delivery is a huge problem, especially in third world countries where they don't have access to what we have here in the United States,
right,
with the same healthcare.
And obviously childbirth for most of humanity's existence was a very deadly, could be a potentially deadly thing, particularly in third world countries where there's no, I guess what, antibiotics and the way to stop bleeding or other things. I mean, women, not that long in the distant past, many women died during childbirth or there was a high risk for it. Is that correct? Am I overstating that? But it seems like childbirth has been for much of the world is not the breeze we make it here.
No, it's not easy.
No.
It's the person who's been through it. It's not easy.
Not easy, right? Well, as Joan Rivers once said, it's like trying to pass a watermelon. You know, it's not necessarily the easiest of things here. All right, having waded too far into the deep waters of being a man talking about things I know nothing about here, where you went to Vietnam with Dr. Trinh, and we're on this recent tongue out trip. Tell me your experience. We had some students on last week talking about their experience. What was your experience? What takeaways did you get?
Yeah, I thought it was beyond my expectations. I originally wanted to go there to learn a little bit more about global healthcare and some of the problems that are exhibited in different countries. Like Dr. Trinh said, what we do here in medicine is vastly different than what other countries do or what is even able to be done. So I was very excited to go and found out that they do cataract surgeries. So for only $38, you could actually cure blindness over there. Whereas here, I think you said it was upwards of $10,000.
$1,000.
Yeah, a couple grand to do the same exact surgery. So I was very excited to go and film so that I can bring our experiences back to the students who weren't able to go. And hopefully help them develop some ideas to innovate both not just here, but really look at how it's different over there and what could they do to help people over there and in their surgeries. But we did a lot more than that, which was even better. And I think that those were the real gems, was things like being able to visit a leprosy colony and understanding that leprosy really still is a thing, and being able to educate students on that and understanding that there are these healthcare conditions that they think don't exist, where people still do need help, I think was really, really eye-opening for me. And I enjoyed that immensely.
So I got to stop you. I want to stop you right there because
Sure.
You touched on the number one theme of last week's show. I don't think most Americans think that leprosy is still a disease. That's from the Middle Ages or something here. That's from a long time ago. It's the Black Plague. And yet it's still prevalent. It still exists in countries like Vietnam. And as Dr. Trinh pointed out, it can so easily be cured.
Yeah.
So to see that there, what surprised you, or what didn't surprise you? What you were amazed by what you saw? Was there anything, you go one step further? Was there some story that you remember? One patient, one person, one place?
Yeah, we did an interview with one of the patients at the leprosy colony. Dr. Trinh and I kind of cut out from the students while they were going, just to have a nice full interview and really understand what one of this one patient, what her needs were. Because that's what I really wanted to look at is unmet needs. What are the things that we're not learning from our patients that they really need? And
what'd you learn? So what'd you learn?
She, of course, was complaining about her wheelchair. Her wheelchair was very old and definitely needed a lot of fixing, which as an old rehab engineer, I really, really wanted to sit there with some tools and do that for her. But the way she used it, I was fascinated by. It was more than just a chair. It was a table. It was holding all of her utensils. She used it to help cook for all of the other patients. And instead of using sort of a soft, cushion that we would expect, hey, you're sitting in this all day long, you would want something soft. She actually she put a board over her soft cushion. And so like a wooden board. And I found that fascinating because that's something you wouldn't have thought about. You would have immediately, as the engineer said, oh, we got to prevent pressure ulcers, right? So this is where you can get really injured underneath your bottom from sitting too long. We need nice cushions. But instead, if it's being used for more than one thing, if it's used as a cutting board, if it's used as a place to hold your soup, you actually do want something very firm. So that was eye-opening to me. And watching how she pulled out a knife out of there and started showing us how she cuts, missing all of her fingers, all of her digits, can still cut, cook, and really help the colony and all the other patients who are further off. And she really was taking care of a lot of the other patients, which I thought was really great, how they do that together as a community.
Dr. Trinh, do we as a medical community, do you as a medical community spend enough time really talking with the patients and saying, what is it you need, rather than arriving and saying, here it is, I have the cure, I have the answer, line up? And people are like, but I really need this. Yeah, well, that's not what we're bringing. We're bringing you this today here. Do we really listen like she's saying? We want to make immediately the engineer says, I'm going to design it for you. Here it is. I've presented the perfect wheelchair. I've tested it. I've tried it. And they say, but where's my cutting board? Do we listen enough?
Absolutely. We don't listen enough, especially in the medical community. We have our algorithms. We have basically
our design specs, our research.
Yeah, we have an entire blueprint ready to go for our patients, when actually we should spend a little bit more time listening to them and seeing what their needs are, what their desires are, and how to meet that. Hey, Arabian's here.
Arabian Prince has joined us here.
Fear the Goat is here.
Are you with us, Mr. Goat? He says he's in. I don't see him there yet here.
I see him. Hold on.
He might be muted.
You're in. And turn on your camera.
Turn on your mic. Turn us on to your ideas here.
Mike.
He's
Let's see.
We're all so good at technology until we have to use it.
Yeah. Absolutely.
This is human-centered design.
Yeah, all right. Yeah.
Why we want to listen to our users more.
It's exactly what we're talking about here, right? Zoom didn't ask me how to set this up. They designed it and handed it to me. As a design, I can give them feedback loop. I can complain, but the first iteration just arrives. Here it is. You'll want this.
Mm-hmm.
And but I want this. Well, we never thought of that. We didn't design it for that. Well, while Arabian's trying to figure out how to join in here, I'll go back to Christine here. All right, so today's topic, that's why Arabian Prince has joined us. You went partly to serve, partly to see and learn, and partly to bring that learning back to others. This notion of virtual reality training. Talk about that. Do we have to sit in a classroom now and look at a book and a slide to learn today, or can we learn through the virtual experiences of others?
So that's where we're trying to transition, we've learned that the old medieval, and this is when it actually started, was in the medieval times, the old way of having someone stand up in front of you and yap your ear off and be able for you to be able to retain all of that information actually doesn't work. Students learn in all different ways. We're all different types of people and we learn differently.
Right.
So what I try to do in my classroom is integrate what we call active learning. So ways of having students do things or interact with me while we're learning that material, while we're learning that content. And one way that we're trying to do this is through virtual reality. We found that clinical immersion, meaning being able to just be a fly on the wall and stand in a medical procedure, really is helpful for students to learn, especially biomedical engineers and medical students, what is going on, what to expect, and how can we innovate and help the people, the physicians that we're going to be working for or working with. Unfortunately, we can't do that for 150 students, right? I can't physically fit them in a room. So we need to get to as close as possible to that real life learning experience. And so they've tried this with videos. The problem is, like most of your children, they will put it at 5x speed.
Right.
They'll put it at 5x speed, and they're not getting the entire room. They're only seeing what the physician is seeing or what the one camera is showing you. Where in reality, in a procedure, you have tons of people. You have technicians who are helping manage the technology, right? The electrophysiology of monitoring the patient. You have nurses who are supporting the physicians that are helping bring the tools, the instruments back and forth and helping them keep things sterile and keep things correct as they're trying to use them. And then you have multiple physicians. Some are telling them how to guide, for instance, where to put the stent in your heart, while the other ones are physically doing it. You'll even get engineers sometimes in the room helping them do that, size it, locate it, figure out how to actually make sure you anchor it correctly. And so without seeing that breadth of patients or breadth of physicians, technicians, nurses, and healthcare workers, you're really not going to be able to understand where the needs are, where the problems are, and for a medical student, where to stand, right?
Yeah, right.
That's actually a big error that they've noticed for very first year early on medical students. So what we've done is we filmed things in 360 degrees. So in a virtual reality setting in real life, as well as in first person. So you can see what the physician is manipulating and what they're attending to, while you can see while all the other supporting healthcare workers, what they have to be doing, what are their roles. And by doing so, we're hoping that we can bring a lot more innovation and a lot more better medical devices that really will fit the needs of the physicians, fit the needs of the patients, and fit the needs of these other workers that, quite frankly, in those videos, they ignore. To help, again, bring those procedures so that we don't have anyone having any medical complications or comorbidities associated with the
So
procedure.
what you're telling me is you can stand up on a lecture and show me, here's how it goes in, here's what I do, or I can tell you, or I can show you. But when you're in the room and there's chaos and people are running around and there's a nurse over here and there's a beep going over here and somebody else is getting something ready over here, suddenly they don't know which way to go. They don't even know where to stand in this whole chaos, this play that is suddenly acting out in front of them here. And in that chaos, mistakes are made, things are missed. You don't see what you're supposed to be seeing. You're not looking where you're supposed to look. You're looking over here. Just like she's looking over there. There's a whole chaos in her house here.
Not right.
I love it.
There's a kid who wants to come on camera here. Yeah, exactly.
I know, right?
That's all right. That's perfect. I love it.
Why do kids and animals always appear in Zoom calls? They sit out there all day long. They'll sit out there and do something else. But the minute you go on camera, kids and cats and dogs all want to appear. I don't know what it is.
I warned them.
There's a study worth having here. All right, so has Arabian Prince joined us? I see him in. Is he with us?
Yep, I'm with you guys now.
So
hey,
what do you think?
Arabian, how are you?
Good. I'm just leaving the meeting, heading to another location. So as soon as I park in like a couple of minutes, I'll
Sure.
put my camera on.
Come
No
on,
worries,
you're playing
Arabian.
golf. We know what you're doing. Don't hide it. You're playing
No, so
golf.
here's a funny thing. Actually, I'm not today. I'm supposed to be
Really?
at Comic-Con. I'm supposed to be at Comic-Con today,
Wow.
but I'm playing hooky until later. So
All right. So I don't know how much of Christine's thing you heard, but she said one of the power, we're talking about her trip to Vietnam and why she films this not in first person, not just one camera, one look at what she sees, but tries to film it in 360 degrees so that the student who watches this stuff can see it in virtual reality. They can look left, they can look right, they can walk over here, and they can see it as much more of a real experience and not just a training video where I'm just taking your eye where I want you to take it. But in the real room, there's chaos and a million things going around, and you don't even know where to stand. What do you think about that virtual reality approach to teaching?
oh no, I think that's amazing. I was just in Toronto. I'm actually going back up to Toronto this weekend at Toronto Metropolitan University, and they're doing something actually similar to where they're not only showing the operations, but they're showing everything else around it. You know, they want to show where the tool sets are. I'm not sure what the technical term is. We know where all the tools are sitting and all of those things. They got to show everything so that the actual student can understand everything that's going on around them. And even like she mentioned, the supporting staff, like what are the nurses doing? What are, you know, some of the other surgical assistants
The engineer
doing,
who's
actually
measuring it and getting ready to stick it
Bingo.
in. Yeah, right.
Yeah, the anesthesiologist, or, you know, I have a friend, I'm learning so much about medical now. I have a friend that all she does is clean blood. Like, what? I have a machine and it cleans the blood. It comes out, it goes back in. I'm like, whoa, that's cool. So, you know, and I'm sure the students don't know about all of these different aspects that they need to learn. And I think that virtual reality and augmented reality is definitely the future of healthcare.
Because now you're experiencing it. You're not watching it. You're in the room. The chaos is all around. Your eye is being pulled left or right when it should be looking straight ahead. There's something beeping over here. Somebody's yelling over here. Something's bumping into behind you. And that, I would think, is, having never been in an operating room, I would think that is critical. That I would bet that's where it all changes. The theory becomes lost in the fog. You know.
Yeah, and you know what? And it's kind of like that one Seinfeld episode where Kramer drops the mint in the patient and no one sees it.
Right? Yeah. Right. Yeah, they're watching it from above, and he spits his mint out, and yeah, right.
Yeah.
Oop, goes right into him here. So, Christine, is this the future? Is this cutting edge, or is this common now, where they're taking 360-degree virtual tours of procedures where I can experience it and not just watch it piecemeal?
Yeah, so we are probably one of the first institutions to do it, particularly for our biomedical engineers. There have been other programs and other startup companies that have tried to develop these virtual reality platforms. One thing I noticed, though, from a lot of them is they're extremely limited. They tend to focus on the very high end procedures. So things like a neurosurgery, where there's other procedures out there that might be more common that really do need more innovation because we've been doing them for so long. It's kind of the if it ain't broke, don't fix it.
Right.
But there are problems that are still broken within those systems. So we tried getting a plethora of different types of procedures, everything from a colonoscopy, which was actually really interesting and very well documented, to
We're going to do a whole show on
procedure.
colonoscopies, folks. We're going to bring you right down into the depth of the bowels here. We're going to really...
Which actually students found very interesting because there is a lot of technology that is used when we do a colonoscopy nowadays.
You know what would be really cool, Christine, is to have you come back sometime and show us these videos live.
Yeah.
Not necessarily live, but show us some of these videos, and we'll broadcast it to OC Talk Radio here, your videos.
Because I don't even know what it
not for
looks
the
like.
squeamish.
Because I know they put a
Sure.
camera down your up your thing or down your thing or through your thing, and this little camera, I don't even know what it sees. It just sees this little. Is it a black and white image or color, or It's in a living.
It's an endoscope. It's usually color. And for instance, in a colonoscopy, you could actually be awake during the procedure. In fact, the patient that I filmed was awake, asking questions the whole time about what was he seeing that's in his own body.
Yeah, what's that?
What?
Can you watch it yourself with the doctor? Whoa, look at that.
You can be awake and watch it yourself with the doctor, or if it's not for you, they can put you under.
What do you think, Arabian Prince? You want to watch your own colonoscopy the next time here? You want to watch your... He might. He's fascinated by all this stuff, but who knows? Well, I think that you could also benefit by watching it again in real time. When you're really experiencing something, it's sometimes hard to take it all in. A football game, a battle, battle somewhere here. And it's only later, like, what happened? Oh my goodness, there was so much chaos, so many things moving around. I don't expect surgery to be as chaotic. It's more planned. That's what the nurses are there for, and they've done this. And there's a process. Hand me this, do this. Kind of everybody knows the dance, I would think. But there's still a lot going on. And I wonder if you step back and watch that again or experience that again, sort of like outside of the moment. If you don't go, wow, why are we doing that? Why doesn't everybody stand over here? Why do we have the tools over there? Why don't we move them over here? Why are we got the problem points where everybody's 5 people are trying to gather and look at something here? Why have we always done it this way? Is there a learning? Do the surgeons learn by watching what they do?
Yeah, and they even actually, I get a lot of physicians who want to do this because they can then take it back and use it as a training tool for their own residents. So I have an ophthalmologist. He does cataract injection. So to prevent your cataracts from reforming and coming back, you have to come back in, and they actually inject a needle in your eye while you're sitting there. Yikes. And he's so good at it. He made us film it so that he could train his residents and train his students into the techniques that he does. And so they might be a little unique, a little different, right? Everyone does things differently, but he wants to be able to show that. And I have others who use this again, because physicians every year will go to conferences and they will review their own procedures, review their own techniques, share what works best with each other. And so this, again, is a nice platform to help showcase what they're able to do or what their own techniques are.
The image that comes to mind is a football player or a baseball player, a professional athlete who spends half of their off time now watching the tape. How did I perform? What did we do? What did we miss in the moment? Oh, my goodness, there's a big hole there. Why didn't we see that in the defensive line? Why did I not see this guy open? What is it? 12? Because they have to learn to watch 20 things at once. And in the moment, they don't see them. So then they review the tape. And plus, they see how the other team plays. He always swings left. He always swings right. You know, there's great lessons to be learned in reviewing past performance, your own and the other people around you. And yet I don't know that physicians have that opportunity to watch and learn and adapt and grow. Oh, I guess I never noticed. I'm always doing this, and I should be doing this. I'm always missing something here. You would think that would make them better athletes.
How do we bring this virtual reality education onto the blockchain or onto the metaverse? Any thoughts on that, Arabian?
Yeah, I mean, it actually is already a part of it. I mean, it's just adding the visuals to the metaverse and to the blockchain and allowing people to have access to it, because, me and you both are all about education. And I think that the more access that people have to a lot of this stuff, like, I often said everyone should be able to see surgeries, right? They should be able to see what doctors do. And a lot of times that will help demystify what's going on. Like I always talk about, I think even for kids, if kids could actually see tonsillectomy, is that what's it called?
Tonsillectomy, I think, right? Whatever.
Oh, did I say it correctly?
You think
oh, nice. There you go. But anyway, if kids could see this kind of thing and then see like the before, the during, the aftermath, and, maybe, it's not that bad. You know what I mean? So I think that by us bringing a lot of the footage that, Christine has already shot into the metaverse could be an amazing step forward for the health, field in general.
Boy, that's an idea I never thought of.
Wow.
We all have fear of surgery. I certainly do.
Wow.
And-
Yeah. It's like, this is what an appendectomy looks like. This is what a colonoscopy look like. And create an index of videos that you can bring onto the metaverse or onto the blockchain.
Yeah, right. So if
Yeah,
you could watch it.
Christine, I would love to see you, like I said, the after. So the before, the during, but literally showing the patient well. You know what I mean? 'Cause I think you can't just leave it off as there's a surgery. Like, well, what happened to the patient? Like, you need to see the patient like eating ice cream or, you know, going about his day and talking about it. It's like, you know what? I was scared when I went in, but it wasn't as bad as I thought.
Yeah.
And I think that complete picture will literally change the face of healthcare as we see it.
Wow. What do you think of that? What do you
We're
think, Christine?
actually, so one thing that we're starting to do now is we're working with the Children's Hospital of Orange County in hopes of being able to do the same procedures, so same filming, not for biomedical engineers. They get to see those because, of course, I get the content, but also for them to use. So, for instance, they actually do this right now for their MRI. So when a child wants to go in an MRI, or needs to, they give them a tablet and it has the chalk bear. The chalk bear walks you through the full procedure, meaning what's the kid doing before, what they have to do, basically sit still for a very long period of time, right, in an MRI machine. And then what do they look like after? Look, they're fine. There's nothing wrong. We're just doing this to be able to image.
Right.
But explaining that to a very young child like my own son is very difficult. So we're hoping, again, we're making this open source because we want hospitals to use it for all different types of content. Mm-hmm. And to be able to create their own stories to really help both their patients as well as their physicians.
Now, what do you have to do from HIPAA compliance? You say it's open source, but maybe I don't want my open appendectomy, my open tonsillectomy used around the world to train and teach people. Maybe it's my private stuff here. It's my body.
Mm-hmm. So we are approved by the Institutional Review Board. This is basically a board that every hospital or institution has to make sure that we're doing things ethically. And I come in and I ask for your consent. Can I use your procedure to be able to train and educate students and educate people? And then in post-processing, after I film, we make sure that we de-identify, meaning we scrub all of the video content for anything that would identify you as a person. Right. So say if your name is written on a wall, we have to completely blank that out. If we can see your face, which surprisingly surgery, we most of the time can't, we cover those with, blankets, but if we can see your face or any other part of something that would identify you, we blur it out. So you basically have a blurry face. But again, this is to protect your own identity. And we do this oftentimes in any sort of study that we want to do that's on a research level.
This is NIH funded, right? What you're doing?
Yes.
Nice.
And how does the NIH feel about? How do doctors feel about this? Are they waiting for this? Are they eager for this? Or are they fearful? Oh, someone's looking over my shoulder. Someone's going to be filming me. Somebody's going to be evaluating me. I don't want anybody watching me.
So I consent both the physician and the patient, because if the physician's like, I don't feel comfortable being filmed, we don't do it. And then they let all of the health staff aware, hey, we're filming today. She's sitting in the corner of the room. I've gone even one step further where halfway through one of my surgeries, one of the nurses said, oh, you're filming? And then just started breakdancing. So, they wanted to be on camera. So it just really depends. But the NIH is very excited about this because they experience the same problem. They would give funds to our institutions to allow for clinical immersion, allow for engineers to come in and watch procedures. But we noticed that only about up to maximum 20 students could do it every year. And this leads to a big equity issue because oftentimes it would be, say, during the summer in a summer program. I worked every single summer when I was an undergraduate.
Sure,
there was no way I would be able to then also do during the day clinical course. So this oftentimes now it's only the privileged that get to go in and do the program. So we want to make it so that it's equitable, meaning everybody can be able to go and do it because it's on virtual reality. So you could do it after work. You could do it right, in your own time. You can do it during the school year, right, as a part of a course, and you don't have to leave, for instance, the classroom or even your own home.
You can be sitting in your car like Arabian Prince, and you could be watching virtual surgery here. Yeah, exactly. You could be golfing.
Yeah.
So is
There you
this
go.
Arabian Prince is great about this. I'm at the UCI's Beal Applied Innovation Center, all about trying to take technology and research and ideas and turn it into something tangible. Is this a tangible new opportunity? Are there going to be, just like there's Hollywood production companies and there are TV production companies, will there be medical production companies that'll come in and lights, camera, action, and set up all the cameras and direct it? And a little closer over here, a little more on this. Let's pick that up. And, do we need a whole film crew there? And is this therefore an opportunity to create a whole new industry?
Yeah, we actually have a competitor. So, yep.
Yeah, right. And would hospitals pay for this? I guess they just build it into the cost of the surgery or something here. But, I don't know if it's expensive to do or hard to do or.
So the competitor company that, like I said, there's other VR technologies, VR procedures out there. What they actually do is they make it a subscription service because that's the best business model.
Yeah, right.
Keep people coming back. Where
Ongoing
to
revenue.
do. Yep. To continue your revenue, physicians themselves will actually pay to be able to access their videos and their video content of, again, these very specialized procedures.
Right.
And this is to help them for when they need to renew their licenses, right? So believe it or not, Dr. Trinh has to take a test every once in a while.
Interesting. So how does it help them pass their license? It shows that they're proficient, or it just reminds them?
And shows the latest of what the procedure is, right? The protocol and what they're doing.
Is this, I'll give you one more rabbit hole to go down. This is probably one nobody wants to go down, but legalities. There's a huge industry for suing doctors because they screwed up. And there's all sorts of malpractice insurance to protect this. And doctors are human and they make mistakes, they miss things. Would this help the defense? Would this help the prosecution? Is this suddenly something lawyers are salivating on? Like the body cam photos of cops, what did they really do at the stop? What did they really do in the procedure? Did they miss something, or did they, no, we got it right?
So oftentimes we're doing common procedures, so the physicians know they're going to be filmed that day. Right. I think because they have things so well recorded, there are cameras already in every hospital procedure in every room, so they can still use those for litigation purposes. Right. This is focused more on education. Right. And so, for instance, I'm sure Dr. Trinh has done this, they have other physicians review cases. So when there is a mistake made, they go through an entire sort of big deck, right, of everything that happened in that room at that time, everything that was recorded, what happened, what ended up happening to the patient that caused the problem. And then they have other physicians, experts review that to see really was a mistake, what can the hospital do to make it better, et cetera.
Right, exactly. Because, part of, there's no question, humans are humans, they make mistakes. That's why, we try and do everything we can to mitigate it. And one of the things to mitigate it might be learn from the mistake. Let's not do that mistake again. Let's find a better way to do something, or a better process, or better procedure.
So, Christine, are you in the phase of continuing to collect obviously more content and more video, or do you have videos ready to go, looking for a platform, or where are you at in all this?
Sure. I'm still collecting content. Like I said, we're just started partnering with Children's Hospital of Orange County because I want to get some children, right, some under 18. It's a more higher risk population, right, obviously, to film procedures, because I think those would be really helpful. But we also have some content already available. So what we're doing is we actually just piloted our course last spring using the information that we receive from students, right, our beta testers, to improve upon our own platform. And we're looking for ways to be able to stream it and ways to be able to get it out into the metaverse.
I think I know some guys that have a metaverse platform. I don't know if we've had them on this show or not, but I heard somebody talking about this somewhere.
MD Dow.
Is this a potential use? You guys have talked extensively about MD DAO. It's a DAO. It's a decentralized something organization here. It's one of these things where it's like a co-op. The members get to decide what happens. They have a vote in where we go and what we do and how this platform develops. They're not just members who come in and say, "What did you come up with this week?" I wonder if I would never have thought of virtual reality. What would you call it? A tour, a tape, an experience a colonoscopy for yourself here, a tonsillectomy or something here. But is this a potential source, place, use for this platform, guys?
Yeah, 1,000%. That's always been our vision, is to offer information and knowledge to anyone who had questions about healthcare. And by putting, this type of footage in the metaverse, I think it's really, really going to help. Because imagine, like we talked about earlier, if you've got a surgery coming up and you're, normally you just talk to your doctor or the nurse and they tell you about it, and you go online and you go on Google and you get some information about it. But now you can actually go into the metaverse or go, I'm not sure. I think that's probably right now the only way, unless you guys are you guys partnering with like Meta to get this stuff on Oculus or right now?
So you can actually easily get anything on the Oculus. We right now haven't made it into an app, but we use YouTube as our platform because they're the best in terms of video compression and video streaming. So all of our content right now is available for free on YouTube.
But you don't get the 3D experience on YouTube.
Google Cardboard, Oculus. Yeah. And do the entire 3D experience through your PC, Google Cardboard, Oculus. And then we are even creating PC versions or gaming versions to have multiplayers be able. So you go in with your significant other.
Multiplayer.
Or in our case,
it's a multiplayer game. My tonsillectomy this week here. It's a multiplayer game.
Yeah. So you go on with your team of engineers, medical students, or your team of your family members. And then that way you can all interact and talk to each other while you're doing the experience. And so we're filming even some spaces in LiDAR so that we can recreate even the rooms so that you can walk around those rooms themselves as well.
That's what I was going to say. Could you actually,
very nice.
Is it that much of a 3D experience that like a video game or like a virtual reality game, I can not just look left and look right, but I can walk around the room and look at it from different perspectives and stuff here?
So right now, the live procedures, you can only look around. And so our next stage that we're doing right now is filming in LiDAR, meaning I need to recreate the table, the chair, everything else in video game space. And so that's what we're doing currently as part of our research.
Wow.
And is this I guess I didn't pick up on this. Is this a university funded thing? This is what the university is doing, or is this something you're privately doing and trying to turn into a private company? I know you teach at the university, but is this a private project or is this part of your research at UCI?
So this is part of my research at UCI. I'm funded through the NIH, IBIB, an R25 grant, as well as VentureWell, which if you're at Applied Innovation, I'm sure you've heard of, where they want to see how this can help entrepreneurs. So how can we use this information to help people who are trying to innovate do better innovations?
Because I want to start a company right now. We're in the media, we're in the video business here. I want Arabian Prince and Dr. Trinh to be my first investors here. We're going to start a company we'll show up. Lights, Steven Spielberg shows up in your operating room, says, "Okay, everybody, I need you to stand over here. I need you to do this. Get the lights up here. Hang on, doctor. Don't start yet till we get it." And action.
We would love to have this on our MD DAO metaverse and collaborate with Christina over this. This is the future of education.
Well, and learning. It's not just teaching people what happens. It's and how to do it. It's how to do it better and learn from it and get over your fears and make this what is hitherto been just a private sanctuary of a handful of trained doctors. That's why we put all you guys up on a pedestal. You're superhumans. You climb up to top Mount Olympus, and I don't know what happens among the gods. I don't know how you figure all this stuff out here. But, you know, it brings it down where the people feel involved in learning about it, and students can learn from it in a real world setting, and doctors can learn from it, and everybody can watch and observe and get. It seems like the more information, the better. Is there a downside? Is there a downside to doing this?
I think the mission of obtaining equity, health equity, is so important.
Explain that. What does that mean? Health equity. That sounds like a noble term. I don't know what that means.
It means everyone has access, not just the privileged, not just the ones with big bank accounts, but the inner cities, the communities, the minority population. Everyone has access to quality health, to quality education, and what Christine is doing is bringing that equity to our communities.
Power to the people. Okay, I'm an old hippie. I'm with this. All right. So now, here's one last question. We go back to the Vietnam analogy. How about remote surgery? This seems futuristic to me, but I don't know if I think it's happening now in a certain degree. There's somebody in Vietnam with some limited medical skills up in the highlands, but the doctor who really knows how to do this stuff is at UCI. And using high-tech cameras, I'm going to walk you through how to do some procedure that you wouldn't otherwise be able to. It might not be as good as if I was there, but it's better than nobody being there. Somebody's in the middle of somewhere and has an emergency, and I'm going to walk you through how to do this. Is that possible? Everybody looks like, I don't know. I mean, could you direct a surgery halfway around the world?
I can teach how to do a digital exam.
Yeah, I know. That's your favorite example here.
It's digital. Remember, it's telemedicine. It's digital.
In other words, you're in a third world country and somebody has an emergency or a need. They have an appendectomy. There's nobody there to do it. So if somebody has some basic medical training, a physician's assistant, a nurse, or somebody, or some, I don't know, there's some mid-level person. I know if you guide me through this, maybe I can figure out how to, like they do in battlefields. I don't know how to do this, but it's better than somebody's got to try. And I'm going to try and do something to stop the bleeding or do something. Can somebody, if I had cameras there, could you direct me what to do? Or is that too scary litigation-wise and everything? I'm not going to touch that one. I'm not going to show you how to do this thing because I'm going to get sued.
Well, you're in the field of telemedicine, right? Okay. And so if we train maybe a nurse practitioner in Vietnam, or even a nurse who lives in the rural areas up in the highlands of Vietnam, and we give her a kit of basic medicines, right, to an inventory of antibiotics and blood pressure pills and diabetes pills. Perhaps through a video camera, you can provide that access from a U.S. physician sitting here on a television or on my laptop, right? Chatting with that nurse and with that patient in Vietnam and giving some guidance. So that's a good place to start, to provide access to areas that are remote with no access to healthcare. And I don't know about surgery yet, but at least basic medical care you can provide access to.
Because I've seen it on movies or something. I guess they're just making this stuff up, but somebody's there watching a camera, and I know you're in the middle of nowhere. Doctor, I don't know how to do this. Well, damn it, you're going to have to figure it out. Here, I'll walk you through it. The patient's going to die otherwise here.
I go one step
blue vein, not the
further.
red vein.
Yeah. I go one step further and use technology to make it not idiot proof, but basically accessible so that anyone can use it with very little training. And so that's what we're trying to do with some of these more, like you said, basic healthcare kits. Can we make a wireless health monitor, right, that anyone can put on, that can be on upside down, right? But still work and at least still provide the information the doctor needs to then say, okay, we need to have you take this type of medication instead.
So somebody in a rural village somewhere in Africa or in India could access this stuff and maybe help or prevent or stop something that otherwise would turn into deadly, serious. Whatever.
That's what the metaverse is all about. That's the aim of MD-DAO, is to take down the walls of health institutions and health barriers within cities, within counties, within states. When you go in the metaverse, those walls come down, and this includes walls between countries to provide care.
I know we're running out of time here, but we did a show several years ago about Khan Academy. This famous guy, I forget his name, but Khan is his last name. And his whole notion is maybe we're going to make colleges obsolete, or if not obsolete, we're going to make them available to everybody. You don't have to come to UCI and sit in the classroom. We will have the professors videotape and teach and stuff, so you can be in a village in Africa, a village in Vietnam, and have access to this information. You know, and everybody's like, well, who pays for it and everything else? He's like, I'm not worried about that. I'm just trying to make education accessible to everybody around the world, not to the privileged few who can come and pay the money and take the time and sit there and sit in person, which is kind of a version of virtual learning now. I mean, we're teaching kids virtually. UCI's shut down again, or not shut down, but they have masks on. For a while it was shut down. Yeah. But, you know, all these universities shut down, and they're asking the parents and the kids, we're going to teach you remotely. You can't come onto campus. The learning still goes on. We're just going to do it in a different way. So could we take that learning, that knowledge base, and spread it around the world? Wow. What would that do?
It's coming. It's happening now.
It's coming. All right. Well, I thank you guys for coming on and talking about this. I hope you come back and talk more. And I want to see this footage. I want to see somebody's colonoscopy. I really want to watch this. I think this is must-see TV. I think this is must-see TV. This is like, forget about Friends or whatever else. I got to watch this. Forget about Stranger Things. We had this show Stranger Things. The whole country's enthralled with this bizarre world. What could be stranger than watching my friend's colonoscopy here? That's
it could be stranger.
That would be pretty strange. All right. Well, thanks guys for coming out. Is there any place they can go to learn about what you're doing, or is this all super secret and the public can't find out your research yet here?
No, you can look at ucivr.com. We're still in the process of updating the videos there. And we were just published in the American Society of Engineering Education. If you look up my name and virtual reality education.
And I think it's got to be a podcast coming soon. What do you think, Dr. Trinh? A virtual reality podcast about medicine here, where we not just talk about it, but share examples and and then this show streams live on MD-DAO, and it's a program in MD-DAO, and it's over the internet. I can see lots of ways to take this and expand the story. There's much more to come, I can see. All right. Thanks, guys, for coming on today and sharing this. I got to go home and think about this. I'm going to what the heck did they talk about? Were they really talking about showing somebody's surgery in 3D on in a game that I can go put on some goggles and walk around and be there? I'm not sure I'm ready for all this here, but why not?
Love it. Well, Chad.
All right, take us out, Dr. Trinh.
All right, guys. Thank you, Christine. Thank you, Arabian. We will do some more of this and watch some real videos from Christine. That'll be pretty awesome.
Do we have
Thanks for joining us today, guys.
Do you have to put headsets on when we do this? Is everything here? Do we all have to go get an Oculus Rift and go do this? Yeah, I don't know. We'll find out.
I got my Oculus.
All right. See you next time.
Take care.
All right. Bye.
Bye-bye.
Thank you. Bye.
Well, there you have it. One more reason you got to tune in each and every time to Health Talks, right here in Orange County's only community radio station, OCTalkRadio.biz. Streaming live from our studios here at the University of California, Irvine's Beale Applied Innovation Center.